Good. Well, thank you very much. It's really a pleasure to be here today to talk to all of you. Before I start, I want to tell you a story. When I was in practice, I had a 90-year-old fellow that came into the office, and he came in for a physical exam. So, well, fine. Came into the exam, and we went through some of his problems. And after that, I started asking him about his medications, if he's taking them. And he said he was. And as I was going ahead to prescribe his medications, he said to me, "Well, I'm taking one other." I said, "What is that?" He says, "I take one vitamin E a day." I said, "Well, that's interesting." I said, "Why do you take one vitamin E a day?" He says, "Well," he says, "my performance in bed is about 3 times per week." And I continue to take the vitamin E. He said to me, "What do you suggest I should do?" I said, "Take two." So you never argue with success, as far as that goes. Okay. Practical approaches to acute pain management. See if I have this correct. Oh, oh, that worked. Maybe it's here. No.
Oh, a blue battery? Oh, okay. Well,
Did it go? Oh, back it up. Okay. Well, the definition of acute pain is quite broad. That's not the right slide, but that's okay. Defining, do we get it? Okay. And unresolved acute pain is subacute pain, defined as pain that has been present for 1 to 3 months, can evolve to chronic pain. What we want to do is get acute pain under control. It's easier to treat acute pain, it's harder to treat chronic pain. Chronic pain lasts about 3 months and can be the result of an underlying medical disease or condition, injury, medical treatment, inflammation, or an unknown cause. While he's getting that together, acute pain is an important aspect of patient management in many healthcare settings. The first one is in primary care. If a patient comes in and he is asking about pain in his elbow, for example, first thing to do is to check the elbow. You find out it's tender there. The next thing to do is to ask him what he was doing at the time. All right, is it going to go now? Yeah. And he said he was playing tennis, new at the game, and he was having problems with his elbow. So I said to him, "Okay, show me how you swing." He said, "You swing, the forearm is like this, straight out, the backhand is like this." And he said, "Well, I go like this." When he went like that, of course, curving the arm would give him the tennis elbow. So the situation is such that what we had to do with him is to make sure he was on enough medication in order to get the pain under control, and then make sure he does something at home, like eat or hold on that particular arm. The third thing is therapy. Make sure that he has good range of motion. And if that doesn't work, we send him to therapy. So that's one of the things that we do in primary care. Now, in orthopedics, it's a different story because in orthopedics, of course, the patient has either a knee replacement, a hip replacement, or an ankle replacement, something of that sort. And of course, that patient is on chronic opioids or acute opioid treatment. Right? While they're in the hospital these days, you want to have a very good medication to take that treatment. But what happens is they're out of the hospital in 1, 2, or 3 days. And where do they go? They go to their family doctor. And it's up to that family doctor to make sure that he gets that patient off the narcotics, opioids, and puts them on non opioid type of medication as quickly as possible. Because patient may like the medication. That's how some of the patients get also. So we have to try to change that. Now, in the emergency room department, it's a different story. The emergency room department, patient comes in with an elbow pain. The first thing they do is take an x-ray. Second thing, the doctor says, oh, it's negative. So just take a few Tylenol, go ahead, see your family doctor. Well, of course, the pain isn't under control. He doesn't know how much to take, that type of thing. Doesn't know how much to do. So now he's 2 to 3 weeks behind the treatment. The acute pain is in the other specialties too, but I'm not going to give you any more recommendations there. For the 10 most common reasons for primary care visits in developing countries, hypertension is one of them. Second one is upper respiratory tract infections, which we all get. The third thing is depression and anxiety, which is kind of interesting because in pain therapy, many of these patients that are not under control as far as pain is concerned develop depression, anxiety. So not only are they on pain medications, now you have to give them an antidepressant as well. And of course, this sometimes gathers into the other medications and causes side effects. The big one is back pain. Now, if you're young, you're in your 20s and 30s, picked up something and got back pain or doing something as far as athletics are concerned, and that back pain probably lasts a week or two, and then it goes away. So we're not too interested in that particular type of pain. But when you're 60 years old and you get the pain in your back, then the pain stays for a while. And if that's not under control, you go into chronic back pain, and the chronic back pain is really difficult to treat. Not only that, a lot of people go to surgery for their backs, and sometimes that works, sometimes it doesn't. So the older you get, greater chance that operations will not work. You have to have good pain medication in order for that to be good. Now, this is kind of it's a study by Europe. He interviewed 1,035 patients. What was so interesting at the end was untreated patients were 462. Treated patients are 222. So what's happening? Why are they not taking their medication? Why are not they taking medications appropriately and properly? And that's one of the things that leads to chronic pain when the acute pain is not under control. Stuck again. Yeah. And ineffective treating of acute pain can adversely affect, come on. Okay, some of the other systems, like the cardiovascular system, in which pain can cause increased blood pressure, increased fast heart rate, hypertension, and so forth. Pulmonary system, it could be hypoxia or increase in oxygen, increase in cough, gastrointestinal, nausea, vomiting. Renal system, it may be increase in urination. And then come down with this again and look at the central nervous system. Anxiety, fear, sedation, fatigue. These are the things that creep in. Central nervous system, again, the anxiety and depression that we have to watch patients develop pain. Because the longer they're in the pain, greater chance that they're going to go in those problems. The extremities are because you get the muscle spasm. So that guy that had the elbow problem is not only having pain there, but he's having spasm. Have to get rid of that spasm as well, and you have limited mobility, so you have to get him to exercise. That's the main thing. Heat versus cold, exercise, and getting better in that respect. Okay, acute pain reduces the quality of life. And this is a study by Taylor. And what he's found out that the patients who were given a questionnaire about quality of life before they underwent some orthopedic surgery. They were assessed 7 days later after they were stopped. And what came about was that the quality of life is strongly associated with pain severity. Now we go to the acute pain assessment. We'll go to the next slide here. Pain is a complex experience. And what we're dealing with here is inflammation leading to pain. But pain is related to reduced activity and inflammation of the muscles, weakness, delayed healing. Now, if you ever had a back problem and you're in bed for a couple of days, you know what happens. You're kind of weak. It's difficult to get going. And so the biggest thing here is whatever that part is, get it going as quickly as possible and give them enough medication that they're out of pain. And pain assessment should be multidimensional. Instead of going through this whole thing, let me summarize it by saying that you give the patient the medication, you watch the medication to make sure there's no side effects, you watch the medication to make sure it doesn't interact with the other medications the patient is taking. I have a therapy program either at home or in the community in which the patients can go to one of the uh, centers in order to have a good therapy. Now, pain scales for assessment. I was involved in developing the visual analog scale many years ago because what happens when you go in? What is it, a 3 or 5 or 8? What is this stuff? And is it really good? Well, I had a visual analog line. I drew a line on a piece of paper. I said, "This is no pain. This is the greatest pain you ever had. Take my pencil or pen and draw a line where you think your pain is." And they draw a line, and it's quite accurate. And when they come in 2 weeks later, you give them the same line. And you say, "No pain, greater pain. Okay, where's your pain now?" And you could see if it's to the left of the line, it's getting better. To the right of the line, it's getting worse. So it's a good way of dealing with how much pain the patient is having. Now, if it's a kid, the Wong-Baker facies is a good one because these are facies in which the kid is crying, the kid is grimacing, the kid is looking the other way. There's different faces. And those kids can pick out exactly how they feel by looking at that face. And pain assessment in other different diseases like dementia and so forth, I'm not going to go into those at this point. Now we go to the pain pathways. In acute pain, what happens at the site of damage? What happens in the injury is that nociceptors are on the nerve fibers. The nociceptors, and you probably have heard of them before, substance P, histamine, bradykinin, prostaglandins. These are released and they're on the nerve endings and they go forth to the spinal cord and up the spinal thalamic tract to the brain. Also, toward the end here, you see CZRP and substance P. Those are the enzymes that are released in the brain that causes the migraine headache. And now we have medications for that particular system in which we stop the CRP and the substance P and get those headaches under better control. So this is kind of interesting. And these particular nociceptors now are going to this dorsal horn of the spinal cord and up the spinal thalamic tract. And just to simplify this, you have the patients that are that you can give medications to at the site during the ascension to the central nervous system and up toward the brain, down the descending modulating system, and back out again. And all during this area here, there are medications that can be given to the patients to decrease the level of pain. I won't go through because most of these are given by prescription, and that's not what I'm going to be talking about today. Now, treating acute pain treatment goals. The primary aim of acute pain medication is to provide the treatment that reduces the patient's pain with minimal adverse effects while allowing them to maintain function. That's the biggest thing, function. The second aim is to keep pain, stop that from progressing to chronic pain. And you've got about 3 months to do that before it gets into chronic pain. Once it gets into chronic pain, it's a different area and a different problem. Failure to effective management of acute pain can lead to chronic pain. And here we go again, the injury or surgery that's done. The nociceptors that we talked about is a transient activation. If it's not under control with medication, it goes to sustained activation and sensitization. And if that doesn't work out, by about the third month, you're into chronic pain and a structural remodeling takes place. And that's the one that's most difficult to treat. So it's up to us that within the first 3 months to get the acute pain under control before it gets worse and goes to chronic. Now, developing a strategy to meet acute pain treatment goals, step one is the thorough evaluation, which we do, including assessment of both the medical and the biosocial factors. So we're looking at the anxiety and depression as well as the pain itself. And develop a treatment plan that addresses the causes of pain and to manage pain that persists despite treatment should that occur. And then you monitor patient very carefully. Now, the key points of agreement across treatment guidelines for acute pain is to use that multimodal and multidisciplinary approach to pain management, tending to the physical health, behavioral health, long-term services supports, and expected health outcomes and well-being of each person. And that's critical. And again, it's medication, it's range of motion, exercise, heat versus cold at home. And if that doesn't work out, do physical therapy. Nonsteroidal anti-inflammatories, acetaminophen or a combination, is an effective initial treatment approach for acute pain syndromes. And these are things that are at home. And these are things that we could do. But the problem is we don't use enough of them at the very beginning. And the opioids are there, and in any treatment program, opioids are always shown these are the things to do. Well, this isn't something that you could do at home. Centers for Disease Control guidance, the treatment of acute pain focuses on the opioids. And this happens all the time, that the opioids are the drugs of choice. And those are not something that we need to figure out at the very beginning because we're not into chronic pain at that point. And if they are in acute pain, you get them off the opioids as quickly as possible. Medications used for the treatment of acute pain, one is acetaminophen. That doesn't mean you take the pill now and then. That doesn't mean you take 2 pills a day. That means you got to schedule it. So you got your acute pain, schedule it. 500 milligrams of acetaminophen every 6 hours. That sounds like a lot of medication, right? But you don't need it that long. You got that patient under control pretty quickly. So that's the situation. Of course, if the patient has a liver problem or a kidney problem, you have to lower that dose. But you have to give enough medication to get that patient under control. Now, if the acetaminophen doesn't work out, you can use the ibuprofen or the Motrin. That's over the counter too, and we're able to get that. What do we do with that? We'll use about 400 milligrams to 600 milligrams every 6 to 8 hours. So again, you're getting a lot more medication into the patient. If they don't like to take the medication every 6 hours, use a naproxen. The naproxen is still over the counter every 12 hours. So you could use that medication. The next one is diclofenac, and I like this medication because it comes in a salve. And when you have the salve, you then rub it on the area. Let's take that patient again with that tennis elbow. And most people will take it and dab it on. No, that's not the way to do it. You go around the joint, wrist around the joint, knee around the joint, and you do that every 6 hours. And that keeps the patient in fairly decent control. And if they don't want to take lots of pills, then the salve works fairly well. Now, the other medications like ketorolac, those are by prescription, and I'm not going to actually talk about those. Medications used for the treatment of acute pain, loxicam and celecoxib. It's another medication that's combined with celecoxib, but it is by prescription. But again, it can be used with a nonsteroidal anti-inflammatory. Now, medications used for the treatment of acute pain, again, we have tramadol. This is a prescription drug, but is a very, very convenient and good because it handles the pain, whether it's at the periphery, at the nerve root, up the spinal thalamic tract, to the brain, down the spinal thalamic tract, and out toward the area that's inflamed. And so that's one good medication by prescription. The Panadol is one that's like that. Now, the combination of tramadol modulates pain signaling at multiple levels, which I have talked about. And what's kind of interesting is that there's a combination now called the tramadol celecoxib combination. And we're attacking multiple targets with an optimized celecoxib tramadol condition. Now, what the pharmaceutical companies have done is taking a molecule of the tramadol, a molecule of the celecoxib, and instead of giving two separate medications, they put them together in a crystalline form. So with a crystalline form, both medications are together as one medication. So that's kind of an interesting situation. And if you take a look at it, you have the tramadol on one side, the, the other the other is on the other side, the celecoxib, and in the middle is where it's attached. So actually, they made two separate medications to combine into one. And that's extremely important because the pharmacokinetic advantage of the co-crystal is such that the tramadol, as far as the plasma concentration is concerned, is higher than it should be. You give the tramadol. So it is analgesia, but it then goes higher. You don't need that much. On the other hand, you have the celecoxib that goes, plasma concentration comes up, but not as high as it should be to take care of that pain. And so the situation is such that if you give the tramadol and celecoxib together, you have less concentration of the tramadol with the same degree of same degree of concentration. The other, which was lower than the concentration should be, goes higher combination. So you have the situation in which you have the two together, giving two different ways of taking care of the pain. Now, on the next slide, we see a study. This first part of it is the combination of the celecoxib and tramadol, that's brown and red, and in blue, celecoxib alone, tramadol alone, or placebo. So those were the four drugs that were studied in this particular study. Next slide will now show that the patient's combination, the tramadol celecoxib combination, is in the red. See how that's better than tramadol alone, which is in blue, celecoxib alone, which is in yellow, or the placebo. Right along the line, see how much better that combination is than the two together. The efficacy of the celecoxib tramadol crystal for acute pain is such that then we look at the safety. And the safety, instead of going through all this, the situation is that the tramadol, because it doesn't go as high as it does alone, would give you less side effects and with the celecoxib. So this is showing that the two medications together in crystalline form will have less side effects than the two together, the two separately that are given together. Now, just to show you what's happening in the field of pain right now, this is a VTX 548. Now, this is another type of acute pain medication. And the second portion of it shows 100 milligrams of that medication, and it does a better analgesic effect than the placebo on the left, and greater than 60 milligrams on the right, 20 milligrams on the right, and it's better than hydrocodone acetaminophen, which is an opioid. So that's what we're looking at, a non-opioid type of medication that may be better than the opioid. Okay, let's look at the next one. This is a VVZ 149, and this particular medication shows again placebo in white and the medication in black, showing at almost every one of the points it is better than placebo. And this is very exciting because it is a small molecule, inhibits the glycine transporter A2 system and the serotonin receptor system. This is sort of brand new at this point. And so we're following these drugs very carefully because they're non-narcotics. Well, in summary then, acute pain is very common, and effective management is essential to preserve, restore function, and quality of life, and to prevent acute pain from progressing to chronic pain. And that's the whole key. All current guidelines support a multimodal approach to pain medication and give enough of it, and reserving limited use of opioids to patients with severe pain that cannot be managed with other agents. There are a number of new agents recently approved or in development for the treatment of acute pain. And that should be the last slide. Okay, well, thank you very much for your attention, and I hope this was helpful.
Does anybody have questions? Whoops.
I don't know. That was a cute
Might be
thing.
clear. I'll give you a headache.
I just want to say I've known Gary Ruoff for many, many years, and he's still doing what he always did. And this is very clear report on these things, and very, very well done. So I learned a lot here because I'm an old guy now and I'm doing other things, but this was really a great talk. Thank you.
Thank you very much.
Thank you. One of the obvious reasons people get hooked on opioids is pleasure, more than pleasure, ecstasy.
Yes.
With these non-opioid medicines that you've been describing that work, is there also pleasant side effects often associated?
No, there's no side effects like the opioids
Shit.
associated. The pleasant side effect that they have is getting better.
Gary, that was very nice discussion.
Thank you.
This issue of Scientific American had a very detailed study of the sodium channel receptor blockers, which showed NA7. There, they talked about NA7 and NA8, because apparently there are 17 different receptors in different organs.
Yes.
And the beauty of this drug is that it's not central. So what you said about euphoria, the effect of narcotic, which goes to the brain and make you feel good and then you become attached to it. These new medications don't have such an impact because they act locally, like you inject lidocaine or local anesthesia. This is the same kind of process, except lidocaine get absorbed through the circulation. If you give too much, you can get cardiac arrhythmia and death sometimes. Some people die. These drugs don't only work on the receptor of the pain. They don't go anywhere else.
Yes.
So if you, I don't know if you have seen that article in Scientific American.
Yes.
I have a copy. If you wish, I can give you a copy of them. Thank you.
Thank you.
The last two drugs that you mentioned, are they available to physicians yet, or are they still in development?
They're still in development. Present time.
Okay, because I'm planning to have another knee operated on, and whoop, what I was what I was what I was doing was what you described in terms of getting a lot of Tylenol every
Yes.
6 hours,
Yes.
a lot of Motrin every 8 hours,
Yes.
the max. And but I knew what they were doing that for because I sure didn't want to get hooked on that stuff. But there's still a key area that still needs to be watched. I'd say that with anybody, I just want to my talking reminds myself of is that switch from the opioids that you're given in the hospital to going without that. Managing the pain that switching the medication that you were on in the hospital and getting on the other stuff in a timely way is really, really key. Because if you lag in that, even by 6 hours or so, you can throw yourself off by a week in terms of pain control. It's really critical to not let the pain get away from you or get ahead of you. It seems to me. I don't know. Maybe this is one of these situations where I'm just trying to get myself validated. So I better stop. But I want to ask you to comment.
Well, the situation is such that you start off with the opioids, and the opioids are probably needed for 3 to 7 days, almost maximum. And but when they give you 14 days worth, you're prone to stay on them because the pain is gone. But I think the situation is as soon as possible to try to get into the non-opioid types of medication and gradually decrease it. Don't stop it completely, but decrease it so that by a week to 10 days or so, you're off the opioids and onto the nonsteroidals or the acetaminophen. And they're good medications. The patients don't take enough of them. And even those, if they're keeping the pain away, you just decrease them as we go along. And the pain will go away faster than if you do nothing and take the opioids and then all of a sudden you're stuck and you're calling for more opioids or what to do. The management is such that we should be doing the non opioids as quickly as possible.
Not asking for a diagnosis or cure here, but one of the things I didn't see mentioned up there was the use of gabapentin for pain management, particularly for someone who has idiopathic peripheral neuropathy.
Yes.
And it seems to work sometimes, but then a patient such as myself will be sitting there one evening and my feet feel like they're in a charcoal pit.
Yes,
Yeah.
the gabapentin is used for the neurological disorders, and you stay on that
Mhm.
because I think that's a different problem. It's not an acute pain that's going into chronic type of pain again. You could get it as acute pain as well, but the gabapentin seems to take care of that type, and if it does, you're well ahead of the game. And it's not habit forming, so you're good. Okay, that says it. Yes. Right. Well, you're into the chronic pain problem. And of course, that takes a different type of therapy, but you should stay on what it is, what you have, because it's doing the job for you, and that's fine. And it's not making you take 6 of them or 8 of them or 10 of them. You're on your 3 or 4 a day, and you just continue doing that. If it's taking care of you in life, that's the way to go.
I think that it's a lot easier to just write the 14 days of the opioid. And I think that we undervalue the the physician patient experience, the talking through what the expectations are, why we're doing that. And it's because it's not reimbursed. And I'm not putting that on the physician because I am one. I'm putting that on our medical system. If a patient could avail themselves of part of the presentation that you gave us tonight, I think they would be more satisfied with these alternative to opioid types of pain relief.
Probably I should mention one thing, and that is patients that are into other types of um, treatments, like on an outpatient basis. And we see patients that are taking um, uh, other than narcotics out there, and other than the non-steroidal anti-inflammatories. So those are the types of drugs that we have not investigated or know that much about. So I stay away from those. They're things that are sort of over the counter, and they're said this works for pain, this works for that, that over the counter stuff is usually doesn't work. Oh, marijuana is the other one. I'm sure that's going to come up. Go ahead.
No, as you're talking, there was someone I talked to that was in the hospital, and what I found fascinating was that they had a machine that if they needed pain medication, and I'm sure it was set to not to give them too much, but if they needed it, they could
Yes.
push the button and get it. But the idea is that you didn't have to push the button all the time, but you knew you could push the button if you needed it.
Yes.
And I wonder if that was ever studied in terms of they didn't need as much as they would have taken if it were prescribed to take so much every so often.
Yes, and that if it's given like every 6 hours, that keeps the patient very comfortable. But maybe they don't need it every 6 hours. They push the button at 8 hours or 9 hours, and that's another way of getting the patients off the opioids. So that's a good way of doing it.
Any physiatrists left in this community?
Podiatrists,
Physiatrists.
physiatrists. I think so, but I'm not sure.
Because Brian Visser was, the last one that I was aware of, his office,
Uh-huh.
and he retired, and I'm unaware of any
Yeah,
dedicated practices to pain management.
right. I'm not aware of it. There are people out there that do some pain management, but I'm not familiar with them. They're not doctors.
The expert at the any time.
Yes.
Not know that.
Yeah, we're dealing with more chronic pain with these particular people. And for patients that have the chronic back pain, you can have injections into the spinal cord, steroid injections, which sometimes does a good job too. Because there's a limited amount of things you could do with some of these particular problems. So they do a nice job. They do a lot of injections into shoulders and into knees and that type of thing as well. But we did the same thing in practice.
I would recommend trauma too.
And trauma.
No, for 20 years, I've been terribly failed lumbar fusion surgery that I redid in New York City. Been taking and diabetic neuropathy, 300 milligrams of Lyrica Goblin a day, plus 25 mics of fentanyl patches. So 2 years ago, about this time, I had to make an emergency trip in the morning to pick up my sister in northern Indiana. It's a perfect storm, and I passed out going 75 miles an hour, wiped out a bunch of signs belonging to Indiana, down me, went through some woods. I
woke up as I was going through the woods and I blacked out again, and then I hit a tree. So I was wearing a full body brace, kind of designed myself after the surgery. And that and both airbags went, and I didn't have a scratch on me, much as shock of all the emergency services that ended up. So my wife has MS, and she's getting increasingly dependent upon me. So this was a shock for his family, and so I reduced the pregabalin to 200 milligrams, reduced down the fentanyl to 12 mics. I finally got rid of that a couple months ago.
Mhm.
Said the hell with it, and went into intense physical therapy. Where I run into a few other people periodically.
They're in therapy, right? That's big. That's big time trauma. Yeah. Well,
Four-letter word.
right. The whole idea is taking care of acute pain so it doesn't become chronic. Because once it becomes chronic, you have your other choices. And sometimes you can do non-pharmacological stuff. That's amazing. That be as good as the pain pill itself. So yeah, trying all of those things would be certainly advisable. Oh yeah, I mentioned right. I thought somebody was going to ask me about marijuana, so I was ready for it. And the patients that come in and they tell me they're taking some marijuana. What do you think? I take one dose a day, and when I say to them, take two, because as far as I'm concerned, it doesn't. It really doesn't do much as far as it's concerned. But it's out there and it's everywhere and it's in every store and it's in liquid form, in pill form, suppository form, and everything else. Most of it is placebo. Some people it works on. Uh, I don't have any qualms about it, but I don't recommend it. Let's put it that way. Okay, Susan?
Nice talk, Gary.
Thank
Did you ever in your practice encounter like an athlete with an acute sports injury that's very painful? You treat the acute pain, but then they say, "Oh, gee, I feel really great," and they go out and they re-injure it and they don't ever heal.
Yes. And those particular patients, and we see this in football, we see it in
Send them back in
baseball.
the game.
I mean, that's the nature of the game. So they do get over it. They do get it back again. In time, it's going to become chronic. They won't be able to play anymore. That's why you see them at 37 years old retired completely because of the particular problems. But those particular people, you can't give acetaminophen or ibuprofen. It just doesn't work. But you stick them in a hot bath or a cold bath, that type of thing, and you get them going again. And exercising is probably the best method of taking care of these particular people. But it's an entirely different ball game when you're dealing with the athletes. The other? Okay, well, thank you so much.